All right, so I'm going to talk to you about the alveoli and the ventilation perfusion concept. Okay, so here I have an alveolus and I have a capillary, obviously very zoomed in. Okay, so remember that the lungs are just air sacs, they're just balloons. So the lungs are just for ventilation. Okay, so we're just bringing air in, pushing air out, bringing air in, pushing air out. Okay, so it's just ventilation. Then we have perfusion, which is represented by a Q. Don't ask me why. There's a good reason, but as a nurse, it's not important for me to understand that. I just need to know that a Q stands for perfusion. So when we talk about a VQ mismatch or a VQ scan, we're looking at how well is this system working? How well are we ventilating and then perfusing? Okay? So this is a really important concept. It's fairly simple, but it's going to really help your nursing care when we're talking about lung issues and perfusion issues. And you know that if you don't perfuse something, it dies. So perfusion is one of the most important things that we look for. It's one of the things that we assess for. Think about when we're assessing perfusion of the brain, we're looking at level of consciousness. Perfusion of the lungs, we're looking at SAT, we're listening to lung sounds. Perfusion of the body system, we're looking at cap refill, we're looking at pulses, distal pulses, perfusion of the heart, we're looking at the EKG, we're looking for chest pain, that type of thing. Okay, so we're perfusing all day long, whether you're in a high acuity, low acuity, or a clinic or whatever. Okay, so wherever you are, you're perfusing, or you're assessing perfusion, excuse me. So when we talk about respiratory system, you have to have an understanding of the ventilation perfusion concept. So ventilation, how well we're ventilating, has to do with surface area, okay, and compliance of the lungs. And if there's anything blocking the way, okay. So when you look at the alveoli, in order to perfuse, okay, and what we mean by perfuse is it's exchanging carbon dioxide and oxygen. The lungs need to bring in oxygen to send it to the body, and they need to take the CO2 from the body and get rid of the exhale. Okay, that's the whole process behind ventilation. Bring in oxygen, blow out CO2. Bring in oxygen, blow out CO2. All right. So we need to fill a balloon with air, and once we do that, once there's air in here, it is going to exchange oxygen and CO2. Oxygen goes this way, CO2 goes this way. It's going to exchange and put oxygen into the bloodstream, and it's going to take the CO2 from the bloodstream to blow it out. But we talk about surface area. It's only going to exchange where the capillary is next to the alveolus. So it's not going to exchange over here. It's not going to exchange over here. It's only going to exchange in this area here. Very important concept, okay? Because what if now I said the patient has pneumonia or they have bronchitis? So now we have mucus here. Well, how does that change our exchange? You can't exchange carbon dioxide and oxygen through a wall of mucus, okay? So now we're only exchanging in this area. So the patient is not going to have as much oxygen going into the bloodstream. They're not going to get rid of as much oxygen or CO2 into the lungs. And so now we have a problem with getting the oxygen to the bloodstream. We're going to become acidotic and hypoxemic because our CO2 is going to build up and we're not going to get enough oxygen. Okay? Very important concept. Okay? What if I said the patient has COPD or they have ARDS, which is a video for another day. They have very stiff lungs, okay, or the air is trapped. Well, in order to exchange, every time we breathe in and out, that's one cycle. every time we breathe in and out, we're exchanging oxygen and CO2. Think about a COPD, or they breathe in and they breathe out for a very long time. But that whole time that they're breathing out, they're not bringing in any more oxygen. They're just trying to get rid of the CO2 they still have. So you're going to have a problem with perfusion of oxygen. That's part of why COPDers always have a low SAT. Okay? So that would be compliance. Okay? Blocking would be the mucus. Surface area. It's a balloon. So if we take a deep breath, a big deep breath, we change the size of our alveolus from exchanging here to now exchanging here. We're now exchanging across a larger surface area. More alveolus is touching the capillary. So we're going to get rid of more CO2 and bring in more oxygen. So when we have somebody do the incentive spirometer, turn cough and deep breathe after surgery, give them Narcan because they're too sleepy and they're not taking enough breaths, that all has to do with making more surface area. Okay, so think about things like your patient is a COPDer, they can't get rid of their CO2, we put them on BiPAP. We force air into their lungs, we force the balloon to inflate bigger because they're going to have a larger surface area to exchange. Okay, so that's kind of the ventilation part. Okay, we also have, so that's the lung part, the ventilation part, but we also have the capillary. So we could be ventilating very well. We could be taking nice big deep breaths. We don't have COPD. We don't have any mucus. But we have a problem in our capillary. Okay, maybe we're very vasodilated. If this is very vasodilated, then it's going to take longer to fill this vessel, and you're not going to have as many exchanges, right? Just as with ventilation, every time you breathe in and out, you exchange. Every time new blood passes by, that's when you exchange. So if the blood isn't going by as often, you have a slow heart rate. You have vasodilation. You have a low blood pressure. You have blood loss. If you don't have enough blood going through the capillary all the time, you're going to have the same problem with not as many exchanges for perfusion. Okay? So this is a really important concept. So when you're looking at a patient who has lost a lot of blood in surgery or from a wound or from a trauma or whatever, then you know that they're going to have respiratory issues because they may not have anything wrong with their lungs. They may have had a gunshot wound to the abdomen and they've lost a lot of blood. Why is their SAT so low? Part of it is saturation is the percentage of hemoglobin saturated with oxygen. The other part of it is we don't have as much blood going through this capillary at any given time. And so we're not exchanging as often. All right? If you think about it, if you have a patient who has a low SAT, who with their blood gas and they're in acidosis because their CO2 is high, how do you fix that? Well, while you're waiting for the order for the BiPAP or the invasive respiratory, whatever, okay, have them take deep breaths. That's all the incentive spirometer is for. It makes a game out of taking deep breaths, okay? And that's a nursing thing. You do not have to have any kind of order to say, take a nice deep breath. Okay, so that's something, this concept is so important for us as nurses to understand. It helps guide our treatment. It helps us understand why the doctors order certain things. Okay, so hopefully this has helped, and you can kind of keep this image in your head. I know it's not great art,